Hello and welcome to this presentation on the Planet Youth approach brought to you by the Planet Youth team. I am happy to be here with you today and I appreciate you taking the time to be here with us. My name is Ingibjorg Thorisdottir and this presentation is on the core elements of the Planet Youth model from idea to implementation. The Planet Youth approach is based on the Icelandic prevention model. The model focuses on identifying and ameliorating the social and environmental risk factors for adolescent substance use. In other words, it's about identifying the cause of the causes that cause substance use, with the goal to achieve population-level delay in the onset of substance use. Our focus is primary prevention, that is, preventing the development of substance use before it starts, by influencing the lifestyle and environment of children before the initiation of any drug use. The model is based on 4 assumptions. The first assumption is substance use initiation risk is not randomly distributed in the population. This leads us to consider and design prevention at the ecological level and to consider efforts in line with localities. In other words, the risk of kids initiating drug use is not the same in any different community or environment. So we need to think in a tailored fashion to be able to design approaches that make sense in the context of different communities. Assumption number 2, behavior change is notoriously difficult to accomplish. This means that it's much more effective to focus on the risk and protective factors for healthy behavioral development and to do so before the development of risky behaviors, rather than waiting until such behaviors have become routine parts of kids' behavior. The third assumption, in primary substance use prevention, there are no quick fixes or simple solutions. We need to consider that if assumptions 1 and 2 are true, that is, the risk is not randomly distributed and that behavior change is difficult to accomplish, then we need to acknowledge that primary prevention takes time. And building environments that decrease the risk of substance use behaviors will take time. And the fourth assumption is that short-term, individual-level interventions are appropriate to achieve short-term, individual-level changes. But long-term population changes will require long-term population-level interventions. But in primary prevention, we need to think about how to build into the fabric of society, how the environment leads to enhanced substance use risk. This means that we work with the entire society and our local communities, and not just at a programmatic level. The Planet Youth approach is not an instructional program that is pre-packaged in a conventional sense, but a process structure that facilitates the collaboration or collaborative partnership. Therefore, strong collaboration is at the core of the model. It is a system that allows us to create a link between research, policy, and practice. The model is a long-term strategy that requires the collaborative effort of researchers, policymakers, and practitioners for sustained and long-term impacts. This is often challenging and difficult for many. One reason for this is that practitioners are not necessarily trained in talking to policymakers and researchers, and the other way around. So we really need these 3 major groups of people at the same table at the same time, focusing on the same goals. Research in this setting should be considered a practice-based tool to help policymakers set policies, to help practitioners set goals and objectives for their work. Collaboration is a central feature of everything that we do. This means that there is nobody that tells anybody or everybody what to do. It is a collaborative decision in any given instance. Everything that we do in the model is data-driven. We do not act unless we have validated information that our actions are justifiable. This also means that our actions should be justified at the local level. So, in a nutshell, the Planet Youth approach is really about speeding up and integrating the relationship between research, policy, and practice. This relationship has often been thought to be linear and not reciprocal. That is, researchers create new knowledge. That finds its way into policy. And policymakers build their policy decisions on research, and therefore practitioners are working at the level of practice with the latest information from policymakers. Sounds good, right? Well, we also know that this reality rarely exists. In order for us to make a collaborative effort and move forward collectively, we need to keep key people from all these major three areas at the table. We need researchers to engage and talk with policymakers and administrative leaders. We need those to talk and engage with practitioners, and we need practitioners to give feedback back to the researchers, so that they can refine their research questions and include important questions that practitioners might be more aware of for the future of the model. The model is built on a foundation of 5 guiding principles. Each principle can be thought of as a unique dimension of an overall approach that provides direction for how each step in the community intervention process ideally should be implemented. Although different steps in the process may emphasize a given guiding principle more or less heavily, every step of the model should include each one of these principles. When choosing among competing strategies, the guiding principles can be consulted as a means of identifying the strategy that is most in line with the intended design of the model and local needs. In this presentation, I will briefly go over each of these principles and then the 10 steps to implementation of the model. So the first guiding principle is that we are applying a primary prevention approach that is rooted in the social environment in a manner that it prevents or delays the initiation of substance use by altering the social environment through increasing social and environmental protective factors and decreasing the corresponding risk factors. The second guiding principle emphasizes community action and embrace public schools as a natural hub of neighborhood or area efforts to support child and adolescent health, learning, and life success. This emphasizes community action and uses the public schools as the natural hubs of the neighborhoods or areas, because that is how we acquire access to participants and often run community meetings through those hubs. So the reason why we work with local schools is because the primary unit of intervention is in the neighborhood or the local area. In most places, schools are distributed by geographical districts. That is, children and youth that live and reside in an area around a given school are also likely to attend that school. So by doing measurement at a school level, we are getting an area-based estimate, and that is solely the reason why we focus on working with the schools, since it is a convenient and accessible unit for most of us. It's certainly not because we want to say that everything that happens in the lives of youth is the business of school, or because of how school does their work, just because it is a convenient unit to work with. But we also know that within the schools, we can often address family factors, school, peer, and community social influences. Because once students come together in a centralized platform, such as the area, we have a unit that is measurable, as well as being helpful to plan action and creating and sustaining attention by all community members, bringing them into a cohesive team. Schools can also be really helpful for community-based meetings. Securing the collaboration and commitment of schools for the collection of data is important because then we can routinely monitor trends in both substance use and risk and protective factors. And accessing youth inside their schools gives us a good opportunity to measure what we need to measure on each occasion. So the third guiding principle is about engaging and empowering community members to make decisions using local, high-quality data and accessible data and diagnostics. So this is all about using the data to train our local community members into understanding what it is we're trying to do, revealing what the data is showing to them and to get them to participate in any intervention or any kind of mutual efforts that they want to run. So local team members make all model-driven decisions based on hard data. That is why solid, sustainable, and routine data collection is so important. We rely on local data to capture, focus, and sustain the community's attention on the local factors that are essential to the prevention of substance use. And also that explains why the data analysis and the reporting are done on the local school and community level. So local data is helpful in guiding the selection of strategies and development of community capacity necessary to address the complex problems of substance use. So to accomplish this, we use data that are local, straightforward, and accessible through quick and efficient processing and dissemination. So finally, local and timely data does strengthen the opportunity to accurately describe, diagnose, and inform community decision-making. But that also means, again, that we need to bring and have the right people at the table. The fourth guiding principle is about integrating researchers, policymakers, practitioners, and community members into unified teams, or into a unified team, where we get everyone to this imaginary table to work with on solving real-world problems in their area. The reason why we underlie this component of the model is that commonly the relationships and connections between researchers, policymakers, practitioners, and community members are more theoretical than functional and practical. In this instant, each group tends to function in isolation from one another and also at varying proximities from the problems itself. What we want to do with the model is to take a team science to practice approach that integrates researchers, policymakers, practitioners, and community members into a team that works together solving problems in their areas over long periods of time. This means that if I am the coordinator or the lead personnel in a given community, I need to make sure that experts in the field of prevention, health promotion, and related fields, the parent-teachers organization, policymakers, administrative leaders, and all relevant people are brought to the table to dialogue with one another, because everybody contributes and all are needed for success. So the fifth guiding principle is about matching the scope of the solution to the scope of the problem. The model recognizes that the social conditions that promote substance use among young people emerge from multiple complex sources over time, such as from established social norms that are related to substance use, community economic conditions, prevalence of depression and anxiety and addiction among adults, and also just a lack of interesting and accessible structured leisure time opportunities for youth. The rise of any of these contributing factors is complex, and it also usually occurs over a long period of time. This is really telling us to give long-term problems a long-term commitment. In prevention, often it's about short-term impact and getting change over time with short-term funding, such as grants. But if we truly want to see a systems change, we need to give longer time to prevention. In sum, these are the 5 guiding principles of the Planet Youth approach. So apply a primary prevention approach, emphasize community action and embrace public schools as the natural hubs of neighborhoods, engage and empower community members to make practical decisions using local, high-quality, accessible data and diagnostics, integrate researchers, policymakers, practitioners, and community members into a unified team, and match the scope of the problem to the scope of the solution to the scope of the problem. So now I've gone over these 5 guiding principles of the model. We can all breathe in a little bit. And now I want to drill down into the 10 core steps, which are so heavily informed by the 5 guiding principles. So I'm sure you're going to hear some repetition, but the model is implemented using these 10 core steps. Generally, there will be limited variation on how individual communities implement these steps. And I say limited because completing each step is essential to complete if one aims to prevent substance use among adolescents through community efforts. However, we also acknowledge that communities do vary between them and countries vary between them, and how they use these 10 steps is going to vary. But essentially, the 10 steps can be divided into 3 major groups. So step 1 to 3 focus on building and maintaining community capacity for later model implementations. Sometimes community also have parts of the demonstrated capacity to address the primary prevention of substance use, while other communities may not. We should always be open into utilizing existing resources to reduce burden and unnecessary cost. Steps 4 to 9 focus on implementing a process designed to focus a community attention as well as to maximize community engagement in creating a social environment in which young people become progressively less likely to engage in substance use. The overall emphasis in the model is on environmental change under the assumption that children and youth are by and large products of the social environment. We make changes in the social environment, and as a result, the assumption is that we get progressively better moving forward. And finally, step 10 focuses on the iterative, repetitive, and long-term nature of the model and describes a predictable arc of implementation-related opportunities and challenges. At this step, the local team should reassess its focus and streamline processes for continuation of their work. The successful implementation of the model requires a local coalition or a team that assumes the primary responsibility for the implementation of the model. It has to be absolutely clear who is the main driver at the local level. There are 4 main characteristics of local teams. Those are local ownership and grassroots orientation. In other words, this means the local people that work and live in the area where we are implementing primary prevention activities really need to be the key people at the table. Number 2, the coalition consists of a combination of key community members and a set of professionals serving in key roles. Number 3, coalitions often include so-called local champions, who are respected members of the community and able to mobilize community as well as influence action. Those do not have to be professionals, but just those that have the local know-how, local understanding, local trust, and know the people of the community. And number 4, the most successful coalitions find a way to fund at least one person with paid and protected time to build and maintain coalition capacity. Often coalitions are based on people that already have full-time jobs, doing other things, and this is added to their plate. This becomes very difficult moving forward. Therefore, finding a way to fund personnel and time to carry the main ball is really, really, really important. So this leads us to the second step, which is titled Local Funding, Identification, Development, and Capacity Building. So if referring back to guiding principle number 5, that is matching the scope of the solution to the scope of the problem. This is why the model intentionally emphasizes long-term contracting, grants, and collaboration. This often requires reorganization of existing institutional and organizational infrastructure. And changing the social environment, of course, takes time, so the focus really needs to be on long-term funding. This is difficult for many, but important if our goal is to sustain long-term change in the community. So long-term benefits require that the initial investment and effort should be designed to change the social environment and given the right time to do so. So a 5-year minimum commitment is something that we should focus on to begin with. The third step is pre-data collection planning and community engagement. What this means is that we need to acquire the support from the community, so extend the support of the local coalition that was formed in the first step into the community. We need to raise community awareness related to prevention goals, as well as establish community awareness through educating people about the approach and the model, and also what we're trying to accomplish. So that is making a fundamental change to the community. This is done by making people aware of the basic premise of the model and its emphasis on changing routine social processes. So by informing and educating people about the school data collection and community feedback systems, and by making sure that people understand that making decisions based on high quality data is central to the approach and the well-being of the community. So now I've gone over the first 3 steps that are all about building and maintaining community capacity for later model implementation. Then we come to the 4th step, and this is about creating high-quality data, and it refers back to guiding principle number 3, engage and empower community members to make practical decisions using local, high-quality, accessible data and diagnostics. So in this step, we are focused on the data collection, data processing, and data-driven diagnostics. Annually or biannually, data is collected from each individual school, and this data is used to monitor rates of student substance use over time, to identify local relevant risk and protective factors that contribute to rates of substance use, and to make strategic decisions tailored to each specific school and the community it represents. Population data is necessary for community outreach. This means that very high within-school response rates, that is preferably over 80%, are required, and also no identification of individuals. We don't identify individuals because we're not working on individual behavior change. Instead, we are trying to change the environment. So we use repeated cross-sectional design and not longitudinal design. The major data domains that we work with have been well established within the scientific literature in this area over the years. Those domains are parents and family, the school environment, peer groups, leisure time outside school, in addition to substance use. So assessing issues in those 4 major domains within the local community is a critical piece. The data is analyzed, and community and school reports are prepared and disseminated. This happens very quickly after data collection because we want the data to be used by local collaborators as soon as absolutely possible. Leadership teams and local teams use reports for diagnosis and decision-making about the interventions and/or other areas of emphasis. Step 5 is titled Enhancing Community Participation and Engagement. Changing the social environment requires the collaborative participation of many, and this includes local teams, community members, and parents, such as parents. So effective implementation of prevention strategies requires outreach designed to maximize community participation and engagement in all aspects of the model. We therefore disseminate findings widely. We want everybody to know and understand what is happening in their community. We use appropriate communications and marketing strategies to increase community awareness and understanding of the reported findings each time. So we want to encourage community members to access the dissemination reports, to attend community presentations and goal-setting meetings, to participate in prevention-oriented activities, and also to address barriers to participation by providing, for example, food, childcare, transportation assistance. So basically, we want to use every way possible for people to see and identify with the findings. The dissemination is therefore critical. Usually within 2 to 3 months of each data collection, a detailed report on risk and protective factors, so from the 4 domains of parents and family, school environment, leisure time, and peer groups, and also substance use outcomes, are prepared by the research team and widely disseminated within each school community. Report receivers, that is, the people that give attention to the findings, include different groups. It can be parental groups, school faculty and school staff, other relevant professionals, administrative leaders such as country, municipality, or area representatives, as well as elected officials. So at the central of this work is the coalition, or the team that was formed in the beginning that are in charge of the dissemination. The reports use accessible and clear language that is completely jargon-free. Data is presented in simple format that is understandable for most people, since the goal is that all model reports are readable and easily understood by the majority of community members. The core team, local teams, and those that work with the data professionally should be at this table. School community reports should be shared with the superintendent offices. Each school report should also be shared with the respective school principal. And also, if there are local teams that run the school community, then those should also receive the school reports. Reports and presentation are a key motivator for community action facilitated by the local team. That is, upon report release, a clear dissemination plan should be prepared by the local team and followed by a strategy of how to actually use this information. This can be done through flyers, emails, social media, and whatever you can think of, really. But reports and presentations include no identifying information of individuals and are always in confidential ownership of the local community in hand. So the quick process from collection to report creation makes the information relevant to the local community. Findings are something to act on immediately. And the dissemination acts as a way to gather allies. And by highlighting the most important focus areas and action, we do that based on information. Step 7, the community goal setting and other organized responses to findings. So the desired outcomes of steps 1 to 6 is that the local coalition will have established 3 to 4 widely supported community goals based on the data. So we use the data to tell us what is happening here and also plan on how we are going to react. The goal should be focused on reducing risk factors, strengthening protective factors for substance use initiation and progression. Goals should also include specific strategies that are tailored for success within the community context. For example, providing educational programs, increase parental monitoring, use behavioral contracts, raise municipal and area-based funding for organized activities, and enforce legal limits to the sale of alcohol, tobacco, and any other strategies that would fit within the community and be likely to make an impact. Selections of goals and strategies is heavily dependent on local knowledge regarding what goals will resonate among community members and what implementation strategies are most likely to work in each community. So a key aspect of the model is the reliance on the wisdom of the local coalition, because the local coalition needs to be able to prioritize goal setting that makes sense to them and that is also aligned with the study findings. So step 8, policy and practice alignment. This is a little advanced from what we've been preparing up to this point. So, and once community goals and strategies have been selected, the local coalition works to identify key policies and local mechanisms for achieving the community's intended outcomes and aligning those goals with current policy and practice. So in other words, we can work with our administrative leaders and elected officials and keep them and bring them to the table to identify if there are local policies that we want to change based on what the work has been up to this point. So while step 6, disseminating the findings, focuses on activating the participation of the community at a larger, mass dissemination, step 8 focuses on activating and aligning the policymaking and professional practice communities with the broader community goals. But again, collaboration between local teams and policymakers and administrative leaders is essential for this step. So in step 9, we've made decisions based on the previous steps about what we're actually going to do. So the step is titled Child and Adolescent Immersion in Primary Prevention Environments, Activities and Messages. So after selecting goals and strategies in step 7, aligning them with current policies and practice in step 8, the community is now ready to immerse children and adolescents in the environment to achieve these goals. So the main goal is to change the social environment. The treatment of the model is to expose children and adolescents to changed environments that are aligned with the model propositions about substance use prevention. Therefore, our choice of intervention activities and strategies and goals are really based on the 4 major domains that I have mentioned before: parents and family, school environment, peer groups, and leisure time activities. And we use our high-quality data and local diagnostics to really align with community-specific knowledge about what will work in each community. If we do so, then youth in those environments will be less likely to initiate substance use over time. Therefore, step 9 focuses on maximizing the children's exposure to social environments unlikely to breed substance use. Drawing from my own cultural context in Iceland, I give you examples that many municipalities and communities in Iceland have successfully operated as part of their implementation of the model. So one is that special prevention workers are employed. These are both within the municipalities and also part-time within schools. So we have people with paid protected time to work on primary prevention. The second is parental groups are strengthened at the community level and also at the school level with home and parent association, parental groups, and a venue for parents to meet and discuss. So we managed to decrease late outside hours through both collaborative efforts from legislation as well as parents, because parents are able to talk in unison because they do have a law that they can refer to. And finally, participation in organized leisure activities is encouraged by offering a wide variety of activities, both in sports and culture, and by subsidizing these activities to create equal opportunity for participation, and by having the infrastructure close to the children, that is, in their areas or neighborhood. So we reached the 9th step, and then what? Then it's all about doing it again. So the model really relies on the repetitive and iterative process that increasingly permeates the social and cultural fabric of each school community year by year. Repetition is essential for sustained impact. We are never going to get there in 1 year. Hell, we're never going to get there in 2 years. So we really want to focus on the fact that changing the environment is challenging. We gotta be able to give it the time it deserves, because it also took time for things to develop to the way they are now. Relationships among local coalition and the capacity established between researchers, administrative leaders, policymakers, practitioners, and community members will strengthen over time. So even if it might be difficult to start with, it will strengthen as we continue and on with the process. Similarly, the data collection process, the analysis, reporting, goal setting, and alignment will also deepen with repeated use, which means that when we have these people at the table on a yearly basis or more, we are going to improve our processes over time. Continued use of research findings to evaluate if progress is being made in the selected goals and strategies will lead to reaffirmation by the community to continue the work. The long-term goal is a shift in local culture, and it takes time, so we need to give it the time it deserves. So Planet Youth provides a structured prevention system. We help communities define and operationalize risk and protective factors within the main domains that we have chosen to work with. We process, clean, and analyze survey data, capacity data, and follow-up evaluation data. We prepare and disseminate reports within 2 to 3 months of data collection. The timing is really important because we want to be working with close to real-time data, and 2 to 3 months when you're surveying hundreds or thousands of kids is quite short. We provide guidance in the development of prevention goals and strategies for actions and intervention. But ultimately, the decision on what to do and how to do it in each area lies with the local team. Collaboration is key. We have over 100 active communities using the Planet Youth approach and have implemented over 1 million questionnaires. So we believe that following the 5 guiding principles and the steps to implementation, the model can be implemented in any community. Collaboration, careful planning on the front end, and time are key elements to success. Thank you for your time here today.